All right, it is 1 o'clock in the afternoon, East Coast time. Welcome everybody. Good afternoon, good morning, depending on where you are. My name is Tom Campbell. I am the program manager for the Traumatic Brain Injury State Partnership Program in the Administration for Community Living at the U.S. Department of Health and Human Services. I want to thank everybody for joining us today. This is our first TBI Tuesday session. We're going to be hearing today and discussing underserved population and being populations within the TBI community. This is the first of 5 TBI Tuesday sessions in observance of March being Brain Injury Awareness Month. And this is in lieu of what has been in the past our annual ACL TBI Stakeholder Day. We are expanding, and so we're excited about being able to expand our Stakeholder Day from a single day to actually 5 days, a month of TBI stakeholder attention. And we're excited about that. We're also excited about being virtual so that we can expand the number of people participating. We're looking at more than double the number of people. We're up to over 400 people that normally would be able to come and attend these sessions. And so today there's a lot of folks on the line, and we're excited that you all are able to join us. The webinar is supported, as of all the webinars this month, will be supported by the TBI Technical Assistance and Resource Center. We call them the TARC, the TBI TARC, and they are funded by the Administration for Community Living. You'll see folks helping us out with the presentation along the way. Each of these webinars this month is free and open to the public. So if you have friends that you believe would be interested in future topics, and we'll tell you what those are in a little bit, please let them know. During each of the TBI Tuesday sessions, we are going to be highlighting the work of our TBI State Partnership Program grantees and the work they do in their states, but also the work they do with each other in work groups, creating resources for the larger stakeholder community. We'll also be highlighting our federal partners every day. For example, today you'll be hearing from the Federal Office of Rural Health Policy, and we're excited about that. And also each TBI Tuesday will not only involve individuals with brain injury as presenters, but each of these sessions has been developed with the significant input of people with brain injury. That is very important for a number of different reasons. Before I tell you more about today's session, I have a couple of logistics. And Connor, if you would advance the slides, maybe it's not Connor, it's Terry probably. Advance the slides to slide number 3 for the logistics. Today's session and all the sessions will be in listen-only mode. Please use the chat or the Zoom feature to post questions if you have questions and you need to communicate with the hosts. We will address the questions as time allows us, normally toward the end of the presentation, and as we can. It depends on how many questions we get, of course. Slide 3, there we go. We are live captioning this webinar in English and also providing an ASL, an American Sign Language interpreter. If you don't see the captioning, there should be a button at the bottom of your screen. I believe if you move your mouse, it'll show up and it says closed captioning. So if you don't see that button for any reason, or if you have any other technical issues or you can't see the ASL interpreters, please use the chat feature to chat to our technical experts who will get you hooked up. This live webinar is going to be interactive, and so you will have an opportunity to respond to polls and other questions. So please be ready for that. That'll be an exciting interactive piece that we've got. Next slide. After the webinar, if you have questions or feedback or any kind of follow-up that you'd like to do, please use this email address, tbitarc@hsri.org. They are our support group, tbitarc@hsri.org. Please note this email is not being monitored. We are not monitoring this email during the webinar. If you need us during the webinar, please use the chat feature in Zoom. A recording of the webinar and also a PDF version of the slides that you'll see today will be available on the ACL website, acl.gov, later on. So with all of that out of the way, I want to introduce our first speaker, our welcoming speaker for our TBI Tuesdays, Rhi McCoy-McDeed. She joined the ACL as the Commissioner of ACL's Administration on Disabilities on January 20th of this year, hours after President Biden was sworn in. She provides executive leadership in this role for all of AOD's programs, working to empower people with disabilities to live independently and to fully participate in their communities. Before joining ACL, Ms. McCoy-McDeed served for more than 5 years as the Executive Director of the Central Iowa Center for Independent Living, while they're focusing a great deal of effort on creating a human services agency dedicated to serving individuals not eligible for supports anywhere else. And before that, she was the employment administrator for Iowa's largest community-based provider of employment supports for people with disabilities. Ms. McCoy-McDeed is a nationally recognized expert on disability, diversity, and intersectionality, and has served on numerous boards, including as the Anti-Racism and Equity Task Force co-chair for the National Council on Independent Living, NCIL, if you're familiar with them. For many years, she's assisted not just Centers for Independent Living, but many different human service organizations with racial equity work on behalf of racially marginalized consumers, employees, and leadership. So with that, I'd like to turn it over to Rhi McCoy-McDeed. Rhi, welcome.
Thank you so much, Tom, and good afternoon, everybody. Welcome to this session, which is kicking off 5 virtual TBI Tuesday sessions for TBI stakeholders as part of ACL's recognition of Brain Injury Awareness Month. As Tom mentioned, my name is Rhi McCoy-McDeed. My pronouns are she and her, and I am privileged to be your commissioner for the Administration on Disabilities at ACL. For those of you that are listening along, I will do a brief visual description of myself. I am a middle-aged Black American woman with light complected skin. I have long curly brown hair. I'm wearing a pink top. I'm seated in a white room with white bookshelves behind me that are filled with books. It would be great to be in person like we've been in years for ACL's annual Stakeholder Day. But I'm glad that we can still connect in this virtual environment this week and weeks to come in March. ACL's annual Stakeholders Day has grown dramatically in attendance and participation over the last few years. And fortunately, moving to the virtual environment has certainly not changed that. I believe that we've got over 400 folks that have registered to be with us this afternoon. That's awesome. And I want to thank you all for being here today and for being a part of the ACL programs that are working to improve the quality of the community living for people with TBI, whether that's through the work of the TBI State Partnership programs, the protection and advocacy systems, or TBI research funded by NIDLR. I also want to thank all the folks who worked behind the scenes so that we can offer TBI Tuesdays this month. TBI Tuesday will run today and for the next 4 Tuesdays from 1 to 4 p.m. East Coast time. And we've got a great lineup of session topics. In addition to today's session on outreach for all, brain injury within underserved populations, on March 16th, we have a session that will focus on sustainable partnerships, forging relationships that last. On March 23rd, the session will be on Return to Learn, equal access to education for students with brain injury. The session on March 30th will focus on justice for all, serving individuals with brain injury across the justice system. And our final session, which will be on April 6th, will be on maximizing the effectiveness of advisory boards through full participation. These sessions also aligned with the breadth of ACL's programs supporting people with TBI. The TBI State Partnership programs work over the last 3 years the protection and advocacy systems, and the Neidler-funded research. Our partners in TBI are serving people across the lifespan in all communities in the very important areas of employment, education, physical and mental health, and dealing with difficult societal issues facing people with TBI. Each session this year is led by a TBI State Partnership Program grantee work group. There are 9 total work groups, and 5 of those will host a session this year. Together, the work groups have national impact, and when you add in ACL's grantees supporting infrastructure development in their individual states, you begin to see how we are all helping support advocacy and changing the quality and community living opportunities for people who experience TBI. The overarching focus on equity for this year's sessions aligns well with the Biden administration's priority on advancing racial equity and support for underserved communities. And I am honored to kick off this particular session on outreach to all brain injury within underserved populations. For those of you who might know me, you know that addressing the needs of marginalized populations has been a central interest of mine throughout my career. And it is also a central part of this administration's mission to address racial inequities. And so before I go further, let me tell you a little bit about who I am and what my work has looked like. And thanks again to Tom for offering a wonderful biography of me at the top of our time together this afternoon. But throughout my career, particularly with regards to the work that I did in my most recent place of employment at Central Iowa Center for Independent Living, I really felt the need or the urgency to support the independent living network and the disability community at large to face the systemic barriers that racially marginalized people experience with regards to access to services and supports. The reality of the society that we live in is such that people who are considered the default setting for the disability community typically are white, middle class, of the Judeo-Christian faith, straight presenting, et cetera, et cetera. And the more removed a person is from that default setting in the disability community, the more barriers they inherently experience as far as accessing services and supports, and as far as professionals understanding their particular disability experience. And so that leads to realities that include the fact that racially marginalized children who experience disabilities more often than not experience the preschool to prison pipeline more often than their white counterparts who also experience disabilities. It also means that with regard to traumatic brain injuries, racially marginalized people are more impacted by TBIs than their white peers are. The Native American populations in particular experience TBI proportionately more so than any other racial or ethnic demographic in our country. Coupled with that is the reality that there's a disparity in access to healthcare services and supports, which further impacts the experience of TBI for racially marginalized individuals. And so I take seriously the racial equity priority of the Biden-Harris administration. And I feel that it's my duty and that this is an unprecedented opportunity for all of us who identify as stakeholders, and for ACL in particular, to be seen as a way shower as far as the intersection of race and disability and how it manifests in a variety of ways in our society, in ways that perhaps we don't necessarily think about. According to the Department of Justice, 40% of individuals who are or have been incarcerated experience a disability, and that includes traumatic brain injuries. You know, how often are racially marginalized individuals who experience traumatic brain injuries How often are their behaviors being misinterpreted by law enforcement officers, thus facilitating them being incarcerated for simply acting out in response to their disability? This is a time to have conversations about that. And as I mentioned, we will have a deep dive in with regards to the interface between individuals who experience TBI and the justice system in weeks to come. And so I look forward to observing that particular TBI presentation. I certainly hope that those of you who are able to will attend that as well. I hope that after some brief remarks, all of you will have questions for me, of course. And I promise if I don't have an answer for you today, I will certainly work on finding an answer for you and getting that answer to you as soon as I am able to. So the CDC reports confirm what many of you already know. Outcomes for people from racially marginalized populations are far below what they should be. I briefly mentioned that moments ago, but the CDC reports that racial and ethnic minorities are far less likely to receive follow-up care and rehabilitation services following a TBI than other racial or ethnic groups. The CDC data also shows that American Indian, Native American, and Alaska Native children and adults have higher rates of hospitalizations and death following a TBI. And racial and ethnic minorities also are more likely to experience negative outcomes overall compared to white patients, compared to white peers. And we know that disparities related to TBI also exist in other ways. And the CDC has indicated that people in rural areas are at a greater risk of dying from TBI than people in urban populations, and that homeless individuals are 10 times more likely to have a history of moderate to severe TBI. That's really staggering. We know that all lives are valuable and that these inequities are certainly unacceptable. If we are to address these disparities, we must address the systemic racism behind these inequities. And that's why the topic of today's session on underserved TBI populations is so important. So to starting the conversation that will help us to break down the barriers that will help create greater equities. The list of underserved populations is, if we're to be really honest with each other this afternoon, very long, and it includes children, youth, older adults, justice-involved individuals, as I previously mentioned, racial and ethnic marginalized people, Native and tribal populations, rural populations, individuals with substance use disorders, homeless individuals, survivors of domestic or intimate partner violence, individuals with co-occurring developmental, intellectual, physical, psychiatric, sensory, cognitive, and/or emerging disabilities. That's a very long list, certainly, but I can assure you that this administration's goal and our goal at ACL is to address this issue with renewed energy while continuing the important work that we all have done, and frankly, what you have led. And it's important that we acknowledge how COVID-19 has been particularly impactful for people who experience TBI, especially those who are underserved. COVID-19 has changed the way support systems operate, often not for the better, even with the best of intentions when it comes to underserved populations. COVID-19 has brought with it a host of new barriers, and the TBI program staff have shared with me how our grantees, the state partnerships, and the protection and advocacy systems in particular have worked very hard to address these issues, and many have collaborated to find strategies that are allowing the TBI community to receive supports in the face of these barriers. With vaccination rates on the rise, thankfully, we will see that many of the barriers fall away, but I want to thank everyone listening today who overcame the barriers of the past 12 months. Many of you have had local and statewide impacts, and the result has been a nationwide effort to at least blunt the impact of the pandemic for the most marginalized amongst us. And with the mounting mental health crisis brought on by social isolation that we know acutely impacts the underserved populations I've described earlier, ACL knows that we must make additional efforts to ensure that we are addressing the impact of COVID-19. We also know that many have experienced financial struggles created by the pandemic, which has caused job losses and underemployment. We cannot let the pandemic turn back the clock on employment or anything else, particularly competitive integrated employment. Over the next 4 years, we will build on the great work you all have been doing in your states and improve our ability to address the challenges faced by the TBI community and the impacts of COVID-19 on people who experience TBI. Through our partnerships and programs, again, Tbi State Partnership Program, the Protection and Advocacy Systems, and our NIDLR-funded research on TBI, we will identify best practices that our programs can use to create greater equity across all demographics. We will support our grantees to actively seek out and incorporate equitable practices and guarantee consistent and systemic, fair, just, and impartial treatment for all people with brain injury. And we will support all grantees to expand your outreach and your engagement with underserved populations that are systemically denied opportunities to participate in programs that support their ability to live independently. Together, we can make tremendous progress in the coming years, and we will because we must. I love the fact that ACL is an advocate on behalf of the people that we serve. Our advocacy role is quite rare amongst federal agencies, and ACL takes great pride in our role as advocates. But we take our lead from your advocacy, of course, and no mountain is crossed without determination. We know that the barriers too many people face when TBI is added to the list of reasons they are being marginalized. And we know that we must advocate and we must stay determined if we are to confront and dismantle these barriers. And so today, as we launch TBI Tuesdays, we recommit ourselves to progress, even as the last year may have had many of us working twice as hard as ever to not lose ground. And I really hope that each of you has a great TBI Tuesday conference experience. And now I look forward to answering some questions. And with that, I thank you, and I hand the ground over to anybody who would like to share any questions that they have.
Thank you very much, Rima. If you have questions, post them in the chat feature of Zoom. We're not able to turn on microphones, I don't believe, easily. So if you could post your question in the chat feature, that would be great. And we'll give you a few minutes to do that if you like. I know, Rima, you have to leave at 1:30. Could you talk a little bit, while we're waiting for other questions, could you talk a little bit about what you see as sort of some of the signature challenges of where you sit now as opposed to where you sat before? What does it look like from where you are now?
Signature challenges with regards to, I want to make sure that I
think people with TBI, but more broadly, people with disabilities.
So I think, both with regards to individuals who experience TBI and both with regards to the disability community at large, we unfortunately have a long ways to go with regards to becoming competent around the disability experience of racially marginalized people. I mentioned that the default setting for a person with a disability in this country is white. The data, when data is captured regarding the disability community, more often than not, that data is gleaned from white members of the disability community. And so disability is a very unique experience. It's informed by everything that makes a person. Gender impacts a disability experience. Sexual orientation impacts a person's disability experience. And so race and ethnicity also impact a person's disability experience. There's a cultural piece that needs to be taken into consideration when we're thinking about different communities and what disability looks like there. And so, the overarching, that's something that I really hope we seize the opportunity to focus on during this particular administration. And given the fact that racial equity is one of the 4 priorities for this particular administration, this should be seen as an imperative, I think, for stakeholders that are with us on the call this afternoon. And so, with particular regard to TBI, the provision of services and supports, the creation of networks pertaining to TBI are, in comparison to other disability communities, is a much newer network, so to speak. And so certainly I think that anybody that's familiar with networks pertaining to TBI acknowledges that they're still, in many respects, kind of in a forming phase in comparison to some of the more established disability networks. And so with that comes the opportunity to bring racial equity, cultural considerations, competencies, et cetera, into the fray and prioritize it as this community is deepening an understanding of what it is, what it looks like, and what it can do.
Mm-hmm. Okay, thank you. We do have a couple of questions. The first is about vaccines. Any hope in getting vaccines sooner, or what are we doing about that with regard to TBI survivors?
So with vaccine access, I think is top of mind for everybody. And I am nearing week 7 in my tenure as commissioner, and this is something that has been the top priority as far as conversations and planning are concerned. And so, with regard to specifics as it pertains to vaccine access, I think the reality is that looks very different depending on where you are in the country. And one thing that we are doing right now, as far as ACL and AOD are concerned, is getting an understanding of what that's looking like, and then ensuring that our networks are being as supportive as possible in local areas and in states and in the tribal territories, et cetera. And so I know that that's not a specific answer, but what you hear me saying ultimately is that, by and large, the folks at ACL and AOD since January 20th have been working pretty much around the clock to get an understanding of what's going on as far as vaccine access is concerned, what we need to do to ensure that the disability community is top of mind wherever conversations throughout federal government are occurring as they pertain to vaccine access.
Okay, thank you. Do you have time for a couple more questions? There's several that have come in.
My goodness. So I unfortunately I have a hard stop right now, but how about let's do one more, and then Tom, you and I can coordinate with regards to getting these questions to me and making sure that they get answers.
Of course. There's a couple of questions that and I'll paraphrase, that are focused on minority communities and the distrust minority communities have for people and service providers in the healthcare and TBI service industry. How to bridge that trust gap with the minority communities, whether they're tribal or Asian or Hispanic or whatever the barrier might be.
So I think I really appreciate that question has come up, and I'm sorry that this is the question I'm going to have to step away from the webinar at. The thing is the first step is acknowledging that there is a trust gap. I think that you know, stakeholders, particularly stakeholders that have either peripheral or direct involvement in healthcare settings, acknowledging that this trust gap is here and that it is one of the whys behind the disparity in access to healthcare and ultimately access to services, supports, and treatment for racially marginalized people who experience TBI. Obviously, this is a conversation that could have a webinar all its own. And so I will leave it at that, but acknowledging that this is an issue, I think is a huge and very proactive step that stakeholders can take with regards to beginning the longitudinal conversation that's going to be required, that touches on systemic barriers that racially marginalized people experience. When we talk about systems, we're not talking necessarily about physical barriers to access. We're talking about barriers that are more esoteric, like this one in particular. And so I will leave folks with that tidbit. But that is a simple but powerful step that really needs to be taken in order to address this particular disparity.
All right. Well, thank you very much, Rima, for your time today and for the insight and leadership on this. And we look forward to working much more with you, of course, and I'm speaking now on behalf of the stakeholder community. Obviously, you and I are going to work very closely together in the future. So
yes, we are.
Thank you very much. I know you have to run.
Thank you. All right. Thank you so much, everybody. Enjoy this series this month.
Thank you very much. All right. So we're going to, I'm just looking at the questions as they came in, and we will grab those and take them back and try to bring some answers to those. We don't want them to hang out and not get answered. So now we're going to do a poll, and the poll is to find out who's here, who's here, and who's paying attention. The polling question you see on your screen. You know, in what roles do you self-identify? How do you think of yourself and you can select all that apply here. And I'm not sure how you select them. If someone could explain that.
Sorry, Tom, 1 second. I'm
Sure.
waiting to see if Connor can put it up.
Well, the poll is not currently on the screen yet. So hold your numbers there just a second. There'll be some buttons to push. I see people are all excited about giving us their numbers on chat. Thank you very much. That's awesome. There'll be an easier way to do that in just a minute.
We might have to skip this one. Connor was disconnected, so sorry, we're not going to be able to capture it.
Having internet issues like so many people have these days. We're all heard about Zoom fatigue. I think Zoom gets Zoom fatigue sometimes. So that looks like I'm just.
Oh, there it is.
Oh,
it came up.
There it is. So everybody, look at the. Yeah, there you go. There you go. Look at everybody choosing. That's awesome. It looks like we've got a lot of people that are people with TBIs and their family members. Also identifying many of them as advocates or self-advocates, it looks like. A lot of social workers, care managers, service providers, and we've got a few researchers. That's exciting. And we've got a fair number of government employees, both federal, state, tribal, and municipal. That's exciting. So as you may or may not know, the TBI State Partnership program that we operate here at ACL is a program that's available directly to state and tribal governments. And they work within their state or tribe to build up those systems of supports for people with TBI. And so I'm glad to see so many local government folks on the webinar. How do I share? This button says share results. I'd like to do that. If I push that, what's going to happen? Maybe everybody can see that. All right. So it's very, the new world is a very new place. The technical world is a very new place. I don't know if you all can see that poll, but it's 21 people were people with TBI, 41 with family and friends, 44 self-advocates, 6 people came in as peer specialists or peer mentors, 59 social workers, counselors, or care managers, 19 researchers, and oh, you can see it. Okay, thank you. All right, so I'm going to close that and we'll go to the next slide. So I want to go over a little bit about what we're going to cover today, and I would have done it before Rima spoke, but I knew that she had to leave quickly, so I bumped it to now. So the first part of today is going to be, we've already had it, our opening remarks by the new commissioner on for the administration on disabilities. In just a minute, we'll have a presentation from the Federal Office of Rural Health Policy at the Health Resources and Service Administration, that's HRSA, for those of you following the acronym bingo game. There's not really a game, I just made that up. Grantees who have been working on the issue of underserved populations for a number of years will follow our friend Alexa from HRSA. They are going to discuss some of the more particular challenges facing people with TBI who are living in rural communities. They've also developed a toolkit that helps service providers better serve people with brain injury and it's called Serving Individuals with Brain Injury in Rural and Frontier Communities. I love the term frontier communities. And then we'll have a break. We'll have a break around 2:40 in about an hour. And just so you all know, there will be a break this afternoon. And then when we come back from the break around 3 o'clock, we'll wrap up the conversation around the toolkit with some feedback because we want to make the toolkit as useful as it can be. And we'll also hear from 2 members of our TBI advisory group who will discuss engagement and cultural competency practices for underserved population from their own personal experiences. These are, our TBI advisory group is a group of TBI survivors that help us out at the federal level and help us with any number of things. And so we're happy to have them on today. So the speakers for today, we've heard from Rima. We're going to hear from Alexa Ofori in just a moment with the Department of Health and Resources and Services Administration. After Alexa, we'll hear from Miranda Talkington, Becky Spalding, and Megan Jones. They will be the panel talking about the underserved populations and the resources and the toolkit they've developed. And then we'll hear from Maria Martinez and Eric Washington about their own personal experiences with engagement and cultural competency. So I'd like to move on to Alexa Ofori and how excited we are that she is with us today. Alexa is a senior advisor for the Federal Office of Rural Health Policy at HRSA. And by the way, HRSA is where the TBI program used to be about 6 years ago until it came to ACL. In this role with HRSA, she is an expert on rural health issues, programs, policies, and initiatives. She used to be the program coordinator for HRSA's largest community-based grant program, the Rural Healthcare Services Outreach Program, that provides support to rural communities to expand and enhance the delivery of healthcare services. The issue of rural communities is such an important one. It's so easy to focus on where providing services is a little bit easier. There's not enough services anywhere, but in rural communities, it's a particularly acute problem. So I'm happy to turn this over to Alexa Ofori. Alexa, welcome.
Hello, good afternoon, and thank you for having me. As Tom said, my name is Alexa Ofori, and today I'm going to talk about the Federal Office of Rural Health Policy where I work and the work that we do in rural communities as it relates to rural health, discuss challenges unique to people living and working in rural America, and share some tools and resources that you all may find useful in your work. So the Health Resources and Services Administration, or HRSA, as we call it for short, because we love our acronyms, is an agency that is part of the U.S. Department of Health and Human Services and is the agency where the Federal Office of Rural Health Policy is located. HRSA supports programs that provide high quality health care to people who are geographically isolated, economically, or medically challenged. HRSA does this through a large and vast array of grants and cooperative agreements to a variety of groups and organizations that include but are not limited to community and faith-based organizations, educational institutions, state, local, and private and tribal governments, and private entities. HRSA serves millions of people every year, including people living with HIV/AIDS, people who are pregnant, mothers and families, and those unable to otherwise access quality health care. Next slide, please. So the Federal Office of Rural Health Policy, or as we commonly refer to it, FORP, administers grant programs to improve rural health care and has an HHS-wide responsibility for analyzing policies that affect residents of rural communities. FORP was created in 1987 to advise the HHS Secretary on health issues in rural communities, including the effects of Medicare and Medicaid on rural citizens' access to care, the viability of rural hospitals, and the availability of physicians and other health professionals in rural areas. In line with the mission of HRSA, where it's housed, these grant programs are the grant programs administered by FORP are designed to increase access to care for underserved populations and build healthcare capacity both at the state and the local levels. As you see on the slide, one thing that we did print was Voice of Rural, because the Federal Office of Rural Health Policy is really the only office in all of HHS that just solely focuses on rural issues and, when it comes to health for those living in rural America. So, we like to say that we often try to, work with our rural communities and then give them a voice at the federal level. We also have an HHS advisory committee on rural health and human services as well, that will often make, briefs on various issues as they connect to rural communities. Next slide, please. Thank you. FORP has a range of programming that falls under the 5 divisions within the office. In our policy and research division, we fund several rural health research centers that help us inform us and help policy and policymakers more broadly about rural health issues and how certain policies impact rural communities. Because as we know, sometimes policies that come down and they may impact rural communities one way, which is sometimes different than the way that they impact an urban community. Through our community-based division, we fund a range of community-based grant programs, most of which fit into one of 2 buckets. Programs that fund direct services. So these are services like glucose testing, oral health services, sometimes mental health services, and then programs that are fund capacity building activities. So some of these capacity building activities are the formation of a healthcare network with unique partners, or planning activities for either organizations or partners who intend to deliver healthcare services, but they're still very much in the planning phase. FORP also administers a number of telehealth programs through the Office for the Advancement of Telehealth. So these are grants, research, and technical assistance. And then through the work of our hospital state division, we work very closely with the state offices of rural health. So these are state-based entities, and I'll touch on them a little later in this presentation, that are really kind of the folks at the state level who really know what's going on in rural, and they're able to connect to rural partners. And so our hospital state division works closely with our state rural health organizations to support quality improvement and performance improvement, especially when it comes to rural hospitals and critical access hospitals. And then finally, we have a range of special programming in our strategic initiatives division to address the rural implications of the opioid crisis and folks suffering from substance use disorder. And more recently, we added a program that focuses on supporting COVID activities in tribal communities. Next slide. Now I'd like to give you a sense of the rural health landscape and go over some frequently cited concerns specific to rural population. People in rural areas live 3 fewer years than people in urban areas, and rural areas have a higher death rate of both heart disease and stroke. In 2017 and in 2019, the CDC released a study that showed that folks living in rural communities actually were what did they call it? But anyway, folks who lived in rural communities were dying of the 5 leading causes of death at a higher rate than those living in urban communities. And those 5 leading causes of death included heart disease, stroke, cancer, unintentional injuries, as well as chronic lower respiratory disease, and things such as COPD fall under that umbrella. Rural women face higher maternal mortality rates, and we see that with the closure of lots of OB units. Also, rural populations face greater challenges when it comes to mental and behavioral health, with limited access to care when it comes to mental health. Rural hospitals are closing and have been closing or are facing the possibility of closure due to their low operating margins. And then a lot of folks who are living in rural areas also experience challenges when it comes to access to care due to long distances and lack of transportation. And then finally, I also wanted to note that rural populations are more likely to be uninsured and have fewer affordable healthcare insurance options. And so on top of all of these general frequently cited rural health concerns, I also want to mention that people living in rural areas also tend to be older. Many people are socially isolated, and there's even a lot of diversity in rural America, with many subpopulations under the larger umbrella of rural populations. These include people who identify as Black or African American, tribal and indigenous populations, Latinx, LGBTQ, Asian Americans, and Pacific Island populations, and those are just a few of the many subpopulations. We also see a lot of regional variation, which requires different approaches. So sometimes how you approach communities and work with communities in the Mississippi Delta region are different than how you work with communities in the Appalachian region or on the border health region. And then all of their health outcomes, there are similarities, but then there's also differences when it comes to regional variation. Health workforce issues, especially when it comes to recruitment and retention of providers, also persist in rural America. There is an aging health workforce at the moment, which is leaving a lot of gaps, not only for just general providers like physicians and nurses, but also specialty providers. And then for all the reasons that I listed above, they've really kind of added to the disparities and gaps when it comes to health outcomes when you look at rural Americans compared to urban Americans. So from this slide, what I really want you to take away is that, yes, rural communities have a lot of challenges, but also rural communities are not homogeneous and they are not the same by any means. And this requires a very unique approach when it comes to addressing rural health concerns. Next slide, please. So on this slide, there's a picture of the US as well as Puerto Rico and Alaska and Hawaii. And what I wanted to represent with this slide is to just give you a snapshot of how much of the United States is actually considered rural. So on this slide, on the snapshot of the US, there's a tan and brown area. And so all of that area is really considered rural in terms of geography, while the small areas with the dashed lines are considered the non-rural areas or the urban areas. And then the 3 different color dots they are critical access hospitals, rural health clinics, and federally qualified health center, which are often the safety net providers in rural. So as you notice, in some of those areas on the map, you'll see a large area of that tan brown area that is the rural area, but then you don't see as many of those dots with those safety net providers. So it's really just to give you another visual representation of how much of the US is rural and the availability of healthcare. Next slide, please. So now I'd like to share a few tools and resources that hopefully you can use in your work when you whether you learn directly work with rural populations, or if you're looking to work with rural populations, or you're just looking for more information. Next slide. The first of which is our federal grant opportunities. As I mentioned when I gave our office overview, our office administers a number of federal grant programs, and there are 3 programs in particular that I would like to make note of: the Rural Healthcare Services Outreach Program, the Rural Healthcare Network Development Program, and the Rural Health Network Development Planning Program. These programs vary in the number of years. Some are 1 year, some are on 3 or 4 year cycles, but all of these programs are non-categorical. So that essentially means that as long as an applicant comes in and they address a health concern and they have the data in their application that supports it, it doesn't matter what the health concern is. So it really leaves a lot of room for applicants in rural communities to determine their needs and then write a grant application to address those needs. So that means we see just about every type of program and every type of project that are funded from these. Everything from working with children and school-based care, to mental health services, to programs that focus on veterans, oral health, children with special care needs, unintentional injury, name it, and we, just about everything under the sun. And so this is really a good catch-all for those folks who are maybe looking to do some work when it comes to TBI, more specifically, in the rural health space. Next slide, please. As I mentioned earlier, also, if you're looking to connect with people working in rural health at more so the state level, I highly encourage you to connect with your state office of rural health. They are a source of information on rural health issues and resources, and they also have a very good sense of what's going on in the state level, whether it's funding, whether it's policy, and then they are also connected with a lot of people and organizations that are already working in rural, if you would like to be connected with some others. So at the bottom of the slide, I put a link to the State Office of Rural Health website, so you can find the State Office of Rural Health in your state. Next slide. Thank you. This is Rhi Hub. So this is one of the best websites out there if you don't know where to start when it comes to rural health issues. Rhi Hub really gathers just about everything and anything when it comes to rural health. So we're not only looking at grant opportunities, both federal and then outside the federal government on the state level, or maybe sometimes from foundation, but they also have toolkits. They have several toolkits with evidence-based and promising practice models and approaches if you're looking to do some work in your community and you want to kind of see what works. They also have several fact sheets and data visualization tools. And all you have to do is search for a topic, and you're able to really find something within the rural health umbrella that pertains to this topic. So I pulled out 2 TBI related resources and write-ups. The first is traumatic brain injury surveillance among American Indians in several different states. And another one is diagnosing and managing mild TBI in rural children. Next slide, please. Okay, this slide is where I put a snapshot from the Rural Health Research Gateway. As I mentioned earlier, through the work in our policy research division, we do fund several research centers to do rural specific research, because we often find out that a lot of research is really done at the, in more so metropolitan and urban areas. And a lot of times there's a lack of data and research when it comes to rural areas. And so that's what we fund our rural health research research centers to do. So at the Rural Health Research Gateway, you can also do a quick Google search and see what types of research products are out there. I did a quick search and found this research product that is currently in the works, that is unintentional injuries in metropolitan and non-metropolitan settings by race or ethnicity. And there's also a link at the bottom of the slide for this item as well. Next slide, please. And then finally, our FRHP or FORP weekly announcements. And we do have weekly announcements. And if you would like to know what's going on in our office and like to know when some of our funding opportunities come out, this is a great way to get on there. So we have the email of the contact who runs this. So if you're interested in being added to our listserv, please click on the email for Michelle Daniels, who's that individual, and she will make sure you're added to the list. Next slide. So thank you very much again for inviting me here today. Again, my name is Alexa Ofori. If you have any questions about anything that I spoke about today, you're interested in the resources or the grant programs or other things that fall under the umbrella of HRSA or rural health more generally, I'd be happy to talk to you about it. So feel free to email me at aofori@hrsa.gov or call me. And that's our last kind of HRSA slide if you'd like to find out about HRSA as an agency and learn more. So that concludes my presentation for today.
Thank you very much, Alexa. That's a lot of information, and I love the website with the rural health. I'm jealous of that website. That is an awesome website. Looks like lots of good resources. If anybody has any questions for Alexa and the Office of Rural Health, put those in the chat. I'm curious what you're seeing, Alexa, about the issue of the vaccines came up earlier. What are you seeing in the area of vaccines and rural populations?
Yeah, so we've talked to a lot of our grantees about this. And I spoke to a hospital up in New York, in upstate New York, a rural hospital, and they had actually mentioned that of course, there is vaccine hesitancy that they had been experiencing at their hospital, both among the hospital staff as well as some people living within the community. But then there was also another subset of people who would go into the hospital and they wanted the vaccine immediately. And so there's a lot of people are experiencing a lot of folks at different places, I guess, on the spectrum when it comes to, do I want to be vaccinated or am I experiencing vaccine hesitancy? And so this particular grantee actually utilizes community health workers. And so I know that they had been working on some training for the community health workers about COVID and about the vaccine to really, address vaccine hesitancy as well. And I think CDC also has some great resources on that too, that we've been making sure to distribute to rural communities.
Well, that's great. I don't see any questions, although if people have questions for you, your email is there in your slides, and it's already been posted also in the chat. I think people, I imagine it would be okay for people to reach out to you if they have questions and want to engage you on some of the issues that you talked about today. Thank you again, and I hope you can stay around to listen to some of the other information that's going to be shared, but we're going to move on to the panel now.
Thank you.
Yes, and there's a lot of questions about the slides. The slides will be posted on our website. And I think that we'll make sure you have the actual, it's at acl.gov is the larger website. It's not as nice as the HSRI, as the HRSA website. So it might be hard to find. So we'll make sure we get the actual link up to you.
Tom, the link is in the chat.
The link
a couple of different times.
to the slides. Yes.
Well, it's the current slides, but we will post the recording and the PDF. So right now you can get it from the HSRI website if you want to download it right now.
All right. Oh, good. Oh, good. You can get it now or you can get it later. Either way.
Yes.
Well, terrific. Want to move on. Before we move on to the panel, I want, if you've not moved since we got started, put your arms up, stretch a little bit if you can, do whatever is comfortable and safe for you. Stand up if that's what you feel like doing, and get the blood flowing. One of the things, really interesting articles recently about Zoom fatigue, and so it's a real thing. Please take care of yourself. Please do what you need to do for what you need to, reasons you need to do it. I got up and walked around a minute while I listened to Alexa a minute ago, so that felt good. So please do what you need to do. When we're in person in a big room, we try to give a lot of breaks. We're giving a fewer breaks now, but you can take as many breaks as you like to stand up and walk around. So please take care of yourself. Moving on to the next group that was going to speak. This is a panel of individuals who are representing some of our state grantees. And rather than go through and read their bios, I am going to make the executive choice to let them introduce themselves. Miranda Talkington and Becky Spalding and Megan Jones, please take it away. And if you wouldn't mind introducing yourselves when you start talking.
All right, thanks, Tom. Like Tom said, my name is Miranda Talkington, and I'm from the state of West Virginia, and we are fortunate to have an ACO grant here in the state of West Virginia. And so I'll let Becky and Megan introduce themselves because they'll have a different part as that we go through. Yeah, if you would, next slide, please. So our group has been working on creating a toolkit for underserved populations. And when it comes to underserved populations, that encompasses a lot of people. And so you think it would be really simple to just find that definition, it would exist out there, but that really wasn't the case. And so as our group was working to find that definition that we felt really covered what we wanted to cover through our work, we've came up with this. And so we did some searches and found two different definitions we felt like did try to encompass those, specifics when it comes to underserved populations. And so as we built our toolkit, we kind of thought about it from the perspective that underserved populations are disadvantaged because of the ability to pay, their ability to access care, their ability to access comprehensive health care, or other disparities for reasons of race, religion, language, group, or social status. But then also people who are underserved face systematic and institutional barriers, which prevent them from accessing healthcare and are receiving the same quality of healthcare as people not facing those barriers. And so when we think about quality healthcare, it needs to be safe, effective, patient-centered, timely, efficient, and equitable. Next slide, please. And so there are a lot of populations in regards to being underserved. There are many people that are underserved across, the whole world. And so our group specifically focused on those that are bolded here on this slide when we were creating our toolkit. And so those populations we focused on were rural populations, individuals with substance use disorders, homeless individuals, survivors of domestic or other forms of violence, and individuals with co-occurring behavioral health disorders. And so this is just a small minuscule of those underserved populations. We know there are many individuals that have those co-occurring diagnosis or vulnerable features that do make them underserved. Next slide, please. And so throughout our work, we've been fortunate to work with many states to create multiple products. And so some of those states that have been participating are Alaska, Arkansas. They're all highlighted in blue here on this map of the US. California, Idaho, Iowa, Minnesota, Missouri, Oregon, Utah, West Virginia, and Wisconsin. And so from those states comes, experts in different areas and knowledge. And so we're really fortunate where we've got to bring together a group of people with, a wide variety of expertise. And so through the work of those individuals, we've created a brain injury and homeless toolkit, a brain injury and co-occurring disorders webinar series, complex issues in vulnerable and at-risk populations webinar series, and then we'll be discussing our toolkit in a few minutes. So I'm going to introduce a person with a TBI. Her name is Becky Spalding, and she is from West Virginia, and she's a very powerful advocate. And so I'd just like for her to share her story and what it's been like for her living in a rural community.
My name is Becky Spalding. I've had several health issues that related to my having an TBI. I had a tracheostomy for 3 years, was unable to speak. I was in the hospital receiving health care. As CNA took a personal phone call and left me unattended in the restroom. I had a hemiparesis, and being the person I am, wanted to try to see if I could do it myself. And after waiting and waiting for the CNA who never came back, I attempted to clean myself and fell and had a traumatic brain injury. In trying to find services, first I ran into the problem of I wasn't able to communicate. I am right-hand dominant. The stroke that and heart attack that caused my initial injuries left me unable to write. And the tracheostomy left a large scar tissue while being intubated. Left the scar tissue in my throat. I was unable to talk. A lot of my issues trying to receive help is nobody told me, and as I was not deaf, nobody said, hey, you can use a T2I to communicate. I finally found out for myself, and at that time I was in facility, and when I requested that, I kind of thought, there has to be other things out there for individuals such as myself. And I found through researching the web, Disability Rights of West Virginia, and they give me information about TBI West Virginia, and I've taken it from there. for the simple fact I cannot speak, my civil rights were stripped, and I did, with the help of disability rights, regain my capacity, and I have worked very hard to regain my independence, and eventually I want to return to work, to become a provider for myself, not have to rely on the government. I want, I want to do that. Problems I've ran into, being in a rural area, or transportation. I live about 25 miles from Charleston, West Virginia. The nearest cab company to me is in Charleston, and just to have a trip to the mall will cost me around $100 round trip. And I have reached out to the House of Representatives, legislature, even a senator, and I'm getting no response from them. And I just, it's very, very important that I do things for myself. I'm independent, and I will encourage anyone who has any form of disability to reach out to the programs that are available. And if there's ever any way I can help them, definitely will.
Thank you so much, Becky.
You're welcome.
Okay, and if we can go to the next slide, please. Wonderful. Thank you, Becky, for sharing your experience, and really highlights how in rural areas that survivors often have to be their own advocates.
Yes.
And that kind of brought us to making this toolkit. So thank you so much. My name is Megan Jones, and I'm a research assistant at the Center on Brain Injury Research and Training at the University of Oregon. And to start out, I'll give you a little bit of background on this toolkit. So it's been in development since about September 2019, when as a group, we met at the NASHA State of States. And we discussed the different state initiatives, kind of when you saw that map of our participating states, and maybe the map that Alexa showed that many of our states were in those really rural parts of America. So we have a lot of different experiences in our work group of serving rural populations. And so we were discussing those different initiatives to building capacity for serving brain injuries in rural communities. And through those initiatives, it was communicated to us that rural providers wanted more education about brain injury, increased knowledge of what services and supports were available for people with brain injury, and increased awareness connections between providers so that these survivors of brain injury aren't so siloed in these different areas and having to connect to those resources themselves, that the providers were able to help reach those resources for them. So last September at the 2020 NASHA State of States, we presented an outline of this toolkit. And this toolkit had been organized, presenting 16 different needs in 9 different underserved populations. And we received some really great feedback that while this was really rich and had some great information, it was a lot. And that providers often find themselves with overloaded caseloads, and that this toolkit might be a little bit like trying to take a drink from a fire hose. And so in order to try and mediate that, we gave ourselves 2 pages to try and distill all of the relevant resources that were available nationwide. So you can see here that the purpose of this toolkit is to direct providers to state-level contacts within national organizations to support providers in establishing these relationships. So if you want to go on to the next slide, please. Okay, so in the chat, you've seen that we've put in a copy of this toolkit, and we intended this toolkit to be as self-explanatory as possible. So when it ends up in the hands and providers, that they're able to just take it and move forward. So you can see that there's a key of different providers, and so it's organized by brain injury resources and then general resources. And we would really love it if you could take this break and do whatever you need to do to take care of yourself, but also take a look at this link and maybe click around and see what you think. And then we'll have some directed questions for you after the break. Thank you so much.
All right, so we're going to take a break here. Need a little bit of guidance from the powers that be. We are breaking a little bit earlier than we anticipated. Do we want to take a 20-minute break? I'm looking at Dana, what do you think? 20 minutes?
Yeah,
25
I
minutes?
think we can go ahead and take a 22 minutes, let's say. Meet back here at a 2:40.
2:40. 2:40 Eastern time.
Yes.
It'd be about 22 minutes from now. Thank you very much, and we'll see you soon. Go stretch and do what you need to do.
And again, the link to that toolkit is in the chat. So if you'd like to take a look at it during the break, it'd be much appreciated.
Yes, and so when we come back, we will be talking more specifically and looking for some feedback. The panel has requested some feedback on the toolkit, and to the extent that it is useful and has the kind of information that would be helpful. So please do take some time and look at that if you can, and we will talk to you all in 22 minutes.
And we're going to play some music during the break, hopefully to pump you guys up a little bit.
All right, that was outstanding. My favorite, I have to say, Terry, my favorite ASL interpreter, enjoying the interpretation of Three Dog Night. That was excellent. Wanted to come back and I think there is can we see the slide on the next sessions, the next 4 sessions of TBI Tuesdays? Excellent. I just want to go over these and encourage everybody to register for these. And there'll be over the next 4 Tuesdays from March 16th to April 6th. This is the next one, March 16th, is on sustainable partnerships, forging relationships that last. And as we know, there's almost no service provision that can be done in our communities now without good, strong partnerships. March 23rd, we will be talking about return to learn, equal access to education for students with brain injury. Return to learn, return to play is a well-established area of brain injury, concussion management. And so we'll be talking about some of that on March 23rd. March 30th, Justice for All, serving individuals with brain injury across the justice system. There's not a lot of good information, but the information we do have about the prevalence of brain injury among people involved in the justice systems is really horrific. It is, the percentages are astronomical, and how we deal with that and how we have that conversation can have long-ranging consequences. And so we're going to start talking, continue the conversation about that on March 30th. April 6th, the maximizing the effectiveness of advisory boards through full participation. This is not, primarily this is about advisory boards. The grantees, the TBI State Partnership Program grantees all have advisory boards in their states. And these advisory boards are required to have at least 50% membership of people with TBI. And so how we go about recruiting, providing accessibility provisions for people with TBI to be a part of that, to maximize their participation in the advisory boards, but also how do we get, how do we find them? How do we get the advisory boards to the place where they are able and maximizing this ability to bring people on? It's a lot about person-centeredness. And because it's about person-centeredness, it's primarily about advisory boards, but it's really, even if you're not a grantee or affiliated with a grantee, it's about how do we involve people with TBI in the planning and the strategizing around the services that they benefit from. And so it's a lot about that kind of an approach, and it's really the things that we'll learn are going to be more wide-ranging than just with advisory boards. So we wanted to encourage you to sign up, and I think you can click on the slides, and these are links in the slides to sign up and register for these. So if you go to get the slides, then you can click on these links. And maybe somebody could even put them in the chat if they're not there already. So we want to turn it back to the toolkit and discuss the feedback we're going to get from the toolkit. And I want to acknowledge the folks that have already put some feedback into the chat. I'm told that we don't have an ability to unmute people and let you ask questions yourselves. And so we're going to read them and have Miranda and Megan respond. The first one, Miranda and Megan, are you both unmuted and back on?
Wonderful, thank you, Tom. And we'll also bring on a couple more of our colleagues from West Virginia and Oregon. So Laura, Lori, and Amanda, if you want to come on as well. Thank you.
Oh, terrific. Oh, it's a party now. Excellent.
Okay, and if we could have slide 35.
So I want to, are you ready for some feedback?
Mm-hmm.
So the first comment that I see is from Tracy Kahlo. Great toolkit, exclamation point. What about adding National Respite Network, ARCH, funded by ACL so that individuals and families can access their state respite options? The second tab is the respite locator, and she provides a link there in her chat.
And that's a fabulous resource. Thank you so much for sharing that. It's exactly the kind of thing that we're looking for.
Let's see, any other, now I'm scrolling back down. That was an early one. That was early on.
There's a comment from Karen Farrington as well. She says, I like the toolkit. One thought is to modify the description so there are less organizational mission statements and maybe more about what can be found. E.g., CSAVR has a link for programs in all states and territories, along with contact information for directors in those agencies.
And I want to point out that wasn't just I like the toolkit, it was I like the toolkit with 3 exclamation points.
I like the toolkit.
Thank you so much, Karen. So we have a couple other questions, just kind of leading questions here up on the slides. I'll go ahead and read those out. We want to see, do folks think that the purpose is clear with that mission statement at the top? And if you think that it's meeting the needs of providers in rural and frontier areas, if it's user friendly, because again, that was something that the feedback that we got before that maybe it was a bit too much information. So we want to make sure that this will be a resource that's used in the community, and any other suggestions for improvement. And I'll go ahead and stick the link back up. Bring it back up in the chat. Go.
Megan, can I ask a question while we're waiting for other people to put their questions in the chat?
Wonderful, yes.
I'm curious how you both have done some vetting of this so far. I'm assuming you've sent it out to some folks, and what feedback have you gotten from them in terms of its usefulness?
So this is our first kind of reach out to folks in the form that it's in now.
Okay.
So before it was a much deeper nested toolkit with PDFs on PDFs. And so this is kind of the first entree into the world.
Okay. This feels like a momentous day then.
But I would add to that, that we have in some of the earlier versions, we vetted it with the entire underserved populations group. And then with, and Lori, maybe you can help me with the, was it the State of the States conference where we had, but I'm blanking on the names. It was Sue
We had
Wolf,
Sue
I
Wolf and
believe.
Rachel Ramirez.
Yes. And so we had a group there that we presented it to, and they also provided feedback, and they're some of the ones that kind of said it was too broad and that we needed to narrow it down and be more specific, make it a little more user friendly. So it has been with a couple groups before, a couple groups and earlier versions, and now this is the version based on their feedback that we're hoping to kind of get the final feedback on.
And thanks, Laura. I'll just add to that Sue and Rachel were very clear in stating the importance of relationships, that a tool like this is only as good as it helps to build relationships between providers to provide better services and to connect with one another, so it's both the tool, the links and so forth, and the relationships that get developed around that. And I just want to restate that that's clearly stated in the purpose up front, but I think it bears repeating again that, we all appreciate the fact that we're all here today connected to one another and able to have these kind of conversations. It's a sort of, the toolkit is meant to be a facilitator of that, but not the central only piece. So just wanted to amplify that point.
Thank you, Lori. There's a couple of questions about the accessibility of the toolkit. And I assume we're talking about 508 compliance and that sort of accessibility.
Yes, so the version is 508 compliant. I'm assuming that's the version that you linked, Megan, is the compliant one.
Yes.
And it will be available. It's available at that link there in a compliant form. There was also some questions about the color and color contrast for folks with visual disabilities.
David Boyer says this looks amazing, again with 3 exclamation points. Very convenient to see everything in one place. Suggestions DREDF and
Dredf.
NCD.
Oh, that's Dredf.
Of course it is. Dredf. What is that acronym?
Yes.
They are an organization out on the West Coast, a disability rights organization.
And what is the acronym?
Disability Rights Education and something fund.
Love our acronyms, don't we? That's awesome.
Gotcha. Thank you,
Defense
David.
Fund. Thank you, Dave. I got close.
One of the things I'd like to bring up that Megan mentioned earlier is that we were given feedback to keep the toolkit in this try to create something that's really tight and compact, but with that you lose details, right? So there's sort of this balancing act of how much information do you put into a document to not overwhelm folks, but then you have to own up to the fact we're going to be missing some information that might be useful. So we have in mind, and correct me if I'm wrong, Miranda, Amanda, Laura, Megan, but I think the idea is like there will be a plan for next steps for this toolkit, and one of them could be to have a nicely developed parking lot, but maybe use a better term for that. So all these really rich ideas that are coming forward don't get lost, that they find a home. And it could be this more nested series of PDFs that Megan described earlier would come in that format. But to get out the gate, we just needed something that was tight, compact, and accessible and not overwhelming. So I just want to really respect the fact that there's some really wonderful ideas coming forward. We'll find a home for them. That'll be part of a plan moving forward. But this is sort of this out of the gate effort today.
There's a question about the management of this toolkit over time. Will it go on to the ACL? Will it pass on to the ACL TARC? Will it be in the grantee portal and the resource library? Well, definitely will be in the resource library. How we keep it updated is probably an open question right now. I'm not sure I know the answer to that.
Indeed, that is an open question right now. But so right now, this is not in its final form. We're going to take the feedback that we're getting today and put this in its final form. But when it is done, it will be available.
And I also don't know that there's any plans to make this available in different languages at this point.
Not at this point, but that would be really great. We would like to get it out and have some kind of evaluation of it so folks that use it can give their feedback on it.
Great idea.
And in that process, then hopefully as it becomes a more useful toolkit, that it can be translated as well.
Other suggestions about including mental health resources, suicide prevention lifeline number, they leave that number and text information there in the chat. And Pew says, I like the cute little key things to show you what kind of resource provided. I agree. I thought that was awesome.
And sometimes it's nice to be able to have a little bit of visual cues rather than just text.
There's several comments in the chats about vision and color contrast. Is there recommendations from the group of things that we should consider for this? I know some of them were spacing and font and things like that. I know 508 compliance will fix some of those, but if there's something else that, you know, that we're not thinking on, okay. And I'm copying all these comments so we can review it when we do the
perfect
too.
Thank you so much.
And Wade Hulls from Alaska asks, where in our state do I go to get this toolkit and how is it being applied in our state?
That is a fabulous question. Right now, it's not available yet, but that is our last question that we maybe should move on to. Ideas for dissemination. Where do you think someone might go to look for something like this? Or where might you think to find something like this? Because we would love to make sure that those those people have access to it so they can make sure it gets out to everyone.
And I love that question. I love the way you phrase that question, Megan, because that's why I say to my children, if I don't know, if I have something that I want to remember where it is, I say, if you didn't know where this was, where would you go to look for it? So that's then I know that's where I should put it. If you didn't know where this toolkit was, where would you go to look for it? How would you think it should be disseminated? And that's a great way to think about that. Thoughts around that question?
Wow. Some really
The Brain
Some good
Injury
ideas.
Alliances in every state and
Yep.
and alliances and agencies. The state website, the grantee websites, of course.
Yep.
Wonderful suggestions.
I think that the three main USBIA, BIAA, and NASHA, of course.
Yeah, we were originally thinking, all the organizations that are on this list, we would find partners in those organizations to share it with so that they can share it with their networks. So kind of a circular network there where people who don't know about these organizations and those that do.
Mm-hmm. TBI program manager, state lead agencies, SILCs, state independent living councils,
Mhm.
ADRCs.
Yep. This is great because it's so diverse. So the range and domains of the suggestions coming through, this is exactly what we were hoping for. Thanks, everyone.
No, this is great. State TBI websites, brain injury associations, lead agencies, DHS, wherever you go on the state to find the waiver information. Brainline.org as a resource.
And I put my email address in the chat earlier. I'll go ahead and do that again, but it looks like a lot of folks that are here are very interested in having a copy of this toolkit. And if you'd like to email me, I can put you on a list to make sure that it gets out to you when it's ready.
Good heavens, this was a very popular question. Somebody needs to help me find all the answers. SILS, Crystal Blair says SILS, that's great. Can you email the list out? Rural health, state agencies connected to rural health, that great connection there. Ombudsman.
And if my email could be included in the slides that go out so folks can have that who watch the recording of this webinar, if they have any ideas that they can email me as well.
Michelle DeVore says, I would love to see information on the CPAAA website. Who would like to explain what that is? It's an acronym challenge. Somebody's Googling it right now. I was going to put it in the chat. Except I can't keep up with the chat. There's 40 messages I haven't seen yet. Well, this is terrific. There's a lot of good information here.
Yeah.
Megan's email again is in the chat. Legal aid organizations.
CPAAA is the AAA in her area. So
Central Plains Area Agency on Aging. Thank you, Crystal. We love, and we joke about acronyms, but it's so easy to fall back into our acronym world. The toolkit is why I registered for this presentation. Wade from Alaska says, that's awesome. All right. So if we are, any final thoughts on that, Megan? And anyone else?
Yeah, I just want to thank you all for all your fabulous feedback. And again, if you just want to email me if you'd like a copy of this when it's ready, or if you have any other ideas, I'm happy to get those emails.
That's terrific.
Thank you all for your time
That's
today.
it sounds like it's going to be a great, useful thing once it's out there and in people's hands. So thank you very much for all the work on that, and the whole work group. So thank you very much. I want to turn it over to Dana Fink. Dana, many of you know Dana is the lead program officer on the grant, the TBI State Partnership Program grant, and is one of the most well-connected people to the community. And I'm going to pass it on to her she's going to moderate the next panel.
Thank you, Tom. I was also your DJ for the day. So
You were the DJ.
You know, I want to add
Well,
that title
I have to say,
my,
not often you get a playlist that goes from Janelle Monáe to Three Dog Night. It was awesome. There was a lot of rich ear food in that playlist. Thank you very much.
Come on back to on each of the sessions. We'll be doing that during the break. So come on back for more of that, of course. So the final session, I'm going to introduce our two speakers, Maria Martinez and Eric Harris. Eric Washington. I'm sorry. And if you'll, I think we've got the time, so I am actually going to go ahead and read their bios out because they have some very impressive bios here, and I want you to get a sense of who these folks are. And while I'm doing that, Maria and Eric, if you guys want to start to turn on your videos and unmute, and then we'll go into a little bit of a Q&A around underserved communities, the underserved communities of which Maria and Eric are a part, and some of the successes and challenges that they faced within those communities. So Maria Martinez was the first in her family to graduate from a university, became an educator in art education and English as a second language, worked in the field of domestic violence, substance abuse, and eventually retired from the Colorado Department of Corrections 2010 after a stroke. Maria was in a motorcycle accident in 2007, sustained a brain injury. She has complications with memory, balance, and anger. She realized where she lived, Pueblo, Colorado, had an impact on her recovery. Maria traveled to Denver and connected with the Brain Injury Alliance of Colorado, attending classes, workshops, and events that were provided to those impacted by a brain injury. She became involved with a local brain injury support group, eventually a support leader, today an advocate and peer mentor for brain injury survivors, a member of the Brain Injury Advisory Board since 2019 with MindSource, and that's the grantee in Colorado there. Lead to the National Center for the Advancement of Person-Centered Practices and Supports. And they'll go ahead and say that other acronym there. That is the NCAPS program, which is another ACL program that we support. We support jointly with Centers for Medicaid and Medicare Services to focus on specifically on making systems more person-centered. And so Maria is a part of that group, and also the TBI Advisory and Leadership Group, which the TAL group is the group of all folks with lived experience that guide the work of the TBI TA Center and our work at ACL. So we really could not do the work that we do without the folks on the TAL group there. I'll go ahead and read Eric Washington's bio here. Eric Washington is a former football player for the University of Minnesota and the University of Kansas. His football career ended on September 30th, 2006, due to a concussion and spinal cord injury. After recovering from the neck injury, he returned to graduate with a bachelor's degree in applied behavioral sciences. Today, Eric's life mission is to advocate for people like him, people with TBI, especially those who are also homeless. He also serves as a strong advocate in the high school athletic community, helping student athletes make educated decisions when taking a scholarship and helping their families understand the importance of not rushing back after injury. And Eric is also a faculty member for NCAPS and as well as a part of the TBI TAL group as well. So now we're going to just do some conversational Q&A. I'll pose some questions to Eric and Maria. I'll just start with, I know I introduced you, but if you guys can go ahead and introduce yourself with anything that we may have missed, and if you could talk a little bit about the communities that you represent in particular.
I'll start, Eric.
Okay.
Good to see you. Could you repeat the question? I'm sorry, I got
No,
sidetracked.
absolutely. So just introducing yourself, if there's anything you want the folks to know that it was not in your bio, and then also the communities that you represent.
Maria Martinez, I come from Pueblo, Colorado, and Pueblo County extends, close to different borders like New Mexico, because it has Trinidad and things like that, and out east, Fremont County and so forth. But after I had spoken to Dana and some other folks, I started realizing ever since in the 70s when I left Denver, Colorado, I have always lived in small rural communities. I lived in Greeley, Colorado, Kersey, Colorado. I also lived in Alamosa and Trinidad. So all the communities I live in have always been small. And I think that's the part that I recognized after listening to other people as well today. So thanks.
And my name's, I just changed my name to Eric Harris because Dana changed my name.
Sorry, that's a friend of mine.
Well, now it's my name. It's okay. So I'm actually from Detroit, Michigan. She pretty much summed it up pretty well. I mean, I played sports, multiple concussions. You fall out of trees, you make tree houses, you do backflips on mattresses in the alley. You just bump your head and you get back up. So I've been a part of the TBI community for years and never really knew it. So now it's great to be able to help and give back to people that didn't have a voice, so that's pretty much where I'm at today.
So next question, and as I'm asking questions, folks can also ask their own questions in the chat and I'll incorporate them as well. But next question, can you talk about what are some of the values that are important to your community or communities? In
the urban community, or you could say the neighborhood or this inner city, however you want to classify it, honesty, relationship building, and actually, follow through is probably the things that we value the most. A lot of times, we're afraid to open up to people because when we do open up, there's no follow through. I tell you my fears, I tell you what we need as a community, and then we take this paperwork back to some desk and it just sits there and get dusty. So a lot of times it's kind of almost like, why am I telling you anything if you're not going to do anything about it? You see every year, every 4 years, you see a political push of, hey, we want this, or we'll do this for this demographic, or we'll do this for this population. And then once the person, whoever wins, it's kind of like, all right, well, on to another 4 years. So it's kind of just like, people just need to follow through, and that's what we hold near and dear to our heart.
I think because it's not just that we serve Pueblo itself, we serve people that live in a community of 300 or less. And I think I'm gonna try to say the word camaraderie that we feel together, I think is what we are seeking, whether it be right now because of Zoom that, we value having the ability to be on Zoom and being able to connect with all communities. But at the same time, people are still needing to trust the whole system of being able to obtain the care that they need. And, and actually another part is using other community organizations that will assist us with substance abuse problems and mental health issues, or even just filling out paperwork So that doesn't sit on a desk, right, Eric? You know, so I think those are important values to us too.
There's a comment here, Eric. It says, we need you to run for office to help those folks follow through. So add that to your list.
I'm trying, but you know, I can't never get on the ballot. You know, the ballot keeps changing every once in a while. But also too, to follow up on that question, I think we value representation. And I think that, you know, if we had equal representation across the board, then people would actually believe that it's possible. You know, when I was homeless, if I've never seen a person ascend to where I'm at now, I wouldn't have never even thought it was possible. You know, so I think that once you start having people putting people in place, then people would start to believe, and that's where it starts. You know, you have to believe that things can be better, and then they will be better. So that's important.
Can you talk about what some of the best practices are for service providers or other folks, you know, practitioners? What can they do better to engage your communities besides some of the things you already mentioned?
I'll let Maria go first on this one.
Thanks, Eric. I'm just going to base it on my experience right now. I think I know they see us. I know they see me, and I want them to hear me though when I'm speaking about what my needs are. And I think the other part is that whether it be people that are in the community, bring survivors back in to be part of volunteering, maybe at hospitals or you know, let them feel like they're part of the community. I think providers can give us a lot of direction, but at the same time, I think they don't know what direction to give us. Sometimes they don't even know that there are support systems out there for brain injuries, like brain injury people, like support groups or activities that are being provided. And I think there's a broken link there where I'm not sure why once a person is in a rehabilitation hospital or unit and they're asked and they're discharged and they go into community, you have it until it's completed. After it's completed, then the resources that the providers have sent us to are gone. You know, so my hope is that there will be a consistency of messaging on how to enter into other areas like the Brain Injury Alliance of Colorado or some of these things that we're seeing today, you know, and allowing them to be educated as we are being educated.
Okay, well, I'll piggyback off what she said. I'm gonna make it very simple. So with practitioners and I guess providers, we have 2 ears and 1 mouth. So if we are slow to speak and actually listen, then we'll be more person-centered and we'll listen to the actual person with the brain injury and then, you know, wrap everything around them instead of, I have the education, I know what you need, this is what you need to do to be better. And that's not how it works. You know, I'm a walking ball of motivation, but some people are just not receptive to you know, the glass half full. Some people, they have to go through the stages of grief. They have to, you know, accept certain things and then the process starts. So I just think that if we are slow to speak and kind of just listen, just hear them, let us sift through our emotions as survivors. Every survivor that's on this call right now we're afraid, we're scared, we don't know what's gonna happen, we don't know what happened, we don't know if we'll ever be better, but we have to go through those emotions to become, you know, what we're going to become. So I think that's probably the first thing, the first domino that needs to fall.
And a great question coming in from Crystal here. For all 3 participants, do you feel that peer support groups work?
I've been screaming about peer support for years. I mean, because 99.9% of the brain injury survivors that I speak to, it's always, we get along well because we've been through something very similar. And as, you know, with the professional, if they're a professional at with this certain information, they may have not experienced certain aspects of it. So they would be prone to listen to me before they listen to the professional. So I think that if you have a professional, a peer that has transcended through the stages of grief and acceptance and all those things, and they're at a certain place where they can actually help, they would actually be able to help the survivor go through the process a little more. It would be a little less rockier of a road, than to, like a power struggle. So that's kind of my thought process on it.
And Marie, I know you have a unique take on peer support groups in your own life.
Yeah, I'm a fan of peer support, and I think that's what our support groups are, and in some ways. But we also in Colorado we have a peer mentee mentor support. Boy, tongue tied. But I have found that we help mentors, and no matter if it's a focused on just brain injury, or there's mentors that are providing for services for substance abuse or mental health and what have you. But to me, it's when you take a peer that's going out into the community to support another peer, that just draws in more trust. It brings in people that will take the risk to go beyond just grieving and start moving towards a life of wanting to thrive. And I think that's really important. I think those are the things that we need more and more in our community, and not just in brain injury, but all avenues of it, whether it be for vets, whether it be for, the cultural aspect, I think it's needed everywhere.
And a follow-up question to that from Chris Miller. She asks, how important is it that the peer support comes from other brain injury survivors versus other people with disabilities?
I think it's probably important that it comes from brain injury survivors, because sometimes you need to see progress. A lot of times we always say, especially with this injury, it's not a lot of research, that's been done to where, like, okay, if you have this, if it's I just say a traumatic brain injury, not mild or severe, it's all severe to me. So in my thought process, if you're saying, hey, this person started off here and now he's here, man, if I keep working, I might be able to, get back to close to where I want to be. Or you'll realize that you're a new version of yourself that's even better. It's almost like if you lost your eyeballs and now your sense of smell and hearing just got better, you're like a superhuman. So you'll realize how you can actually be better after. So, but if you see your peer, you're like, okay, I can do this because he's walked the same walk, and that's important to understand. So I think it's very important to have a TBI survivor as a peer.
I agree with that too. I think when there's a commonality, and that commonality is that we have experienced brain injury at whatever capacity, I think that's where people are being heard. Those are the people that are listening. Those are the people that can relate to your emotions, that can relate to what's happening in your community as you try to reintegrate yourself back in the community, because there's a disconnect when you have a brain injury, and you're trying to, especially if you had a job and you lost your job, and you have somebody that has a brain injury, is a peer mentor, and is working, so I think those are important things that give us a feeling like, it's possible. It's a possibility that I could be back out and doing the same things, and hopefully we're when we meet people that we're mentoring, that we find those people that can they also be mentors. Let's bring those people into this whole network of services.
I have something to say on that. I know that through my process of rehabilitation, even seeing someone make progress, regardless of brain injury or other injury, just seeing someone who wants to get better, who wants to re-enter the world, basically. As always, I don't want to say influence, it has inspired me to continue to keep fighting. So, yes, people with the TBI have something in common, but other people who have acquired disabilities have something, how do I say, who can add something to the group. Definitely you want TBI survivors, but I think other individuals with injuries and have deficits from those injuries who are upbeat, making progress, and you can see that progress. Unfortunately, prior to COVID, my area, the TBI but support group was 40 miles away. Every time I would arrange transportation, they would cancel on me or have to work or whatever. I never met another individual with TBI before. And then COVID, and they started doing the meetings by Zoom. And that was the first time in 4 years that I got to talk to someone with a TBI. So,
A nice silver lining from COVID there, I guess.
I mean, if there is one, but I just feel that any disability is a disability, and if you find someone who's placed and doesn't take no for an answer, because my ENT told me I would never speak again. And I'm like, well, yeah, I could accept it, or I could do something about it. Hit my computer, did all the research, worked around the medical bureaucracy, and I'm talking to you today. So,
awesome.
And that disability had nothing to do with my TBI. So I guess that rounds up what I want to say is, though that had nothing to do with my TBI, I overcame that.
Excellent. Thank you for sharing that, Becky. Now I want to know from the others, from Eric and Maria, about maybe how COVID-19 has affected how well your communities are being served, or positive or negative changes that have occurred due to COVID, and how you get services and supports.
I think in the inner city, what happened was you actually seen how far some of the gaps were actually before COVID, because everyone doesn't have adequate internet access, or everyone doesn't have transportation to get around. So what happened was, in the inner city, we have support groups. They're kind of spread out. So you have to go into a building and someone opens the door and you can stay in there. But what happened was, now the transportation shut down, and if you do get to the support group, you couldn't get home, or no one would allow, 15 large men into their job by themselves. So you started to really see how people really were once the pandemic started. So, and then everyone's not a fan of technology. A lot of people think everyone's watching them or spying on them. So no one really wanted to do anything virtually. So, and then now you have the same thing with the doctors. Everything's telehealth. So you don't have adequate high-speed internet to actually be able to see the doctor, and you're trying to talk to the doctor over a cell phone and he's on a Zoom call. It's just not happening. So it was a lot of people already didn't trust, and now you're asking them to go on the internet, give their birthday and information across the web. That's, that could be stolen. It was just, everything is just, it actually created a larger gap in between the healthcare services and a lot of minorities.
Maria, do you have anything to add?
Before COVID hit, we had just received, probably a year or so, a community grant from MindSource, which allowed us to expand and in our services. And the thing that was really interesting was that if we had transportation issues, we were able to provide that transportation to people in the community. And like Eric would say, if after a certain time, all transportation stops in Pueblo when it comes to, serving people with disabilities. And so we were able to pick people up and take them home and stuff like that. And we were also able to mainstream ourselves into the community by utilizing the universities, the community colleges, and working with other community organizations. Once COVID hit, everything shut down. It shut down everything that we were doing out externally. So we had to reinvent ourselves, and we went into Zoom phase. And I think that was beneficial, but it still left a large population of the Pueblo community out. And it still is in that way, in a lot of ways. But we are starting to get people back, which is good, even though we're still using Zoom. And I think the other part of the impact for me was my mother, who's a brain injury survivor too, was able to get her services because I was her caregiver. But as a person being the caregiver to my mother, I couldn't receive services for myself because of the COVID rules that they had. So my care medically has been postponed for a year. And that, I think, that's something that I think we need to look at if we ever break out of this. How do we allow caregivers to be cared for as well as survivors and other people with disabilities? So I think that's an important thing that I need to look at as a whole. How do we continue services to the best of our ability so that we can try to lessen the isolation and the depression and all the other feelings that come with being taken away from your support groups. Because I think it really does have an impact on everybody.
I think people with disabilities, and especially people with brain injuries, are some of the best problem solvers I know. You have to, adapt and problem solve on such a regular basis. And I can just hear that in you guys' responses and how you've adapted to COVID and other challenges as well. It's just so evident. There's a ton of content coming in through the chat here, so I hope I can get to everyone. I'll go to the next question here from Greta. And Greta says, I believe that TBI survivors frequently fall off the grid when traditional insurance coverage has ended. Can you speak to how you were supported after funding ended? What is your view on how this issue should be addressed in the future? And do you have any advice for a professional who wants to create ongoing care options for survivors who need more? That's a lot of questions. So the first question is, can you speak to how you were supported after the funding ended from traditional insurance, if that was something that you experienced? And that's to, I'll pose that to Maria, Eric, and Becky, whoever wants to jump in for that.
I could jump first. So I'm dealing with chemotherapy, brain injury, a whole bunch of stuff kind of in one box. And sometimes, while we're trying to build peer-to-peer programs and build, teach people self-advocacy, sometimes you're forced into self-advocacy. And I kind of was forced into insurance didn't want to pay for this and insurance didn't want to pay for that. And sometimes you just got to just start knocking on doors and see what you find. You can't allow a disability never turns off, a TBI never turns off, so the funding shouldn't turn off, because a disability is not just from 9 to 5. Then we go home and it's like, oh, I'm okay, I don't need any help, and then it just pops back on when everyone goes back to work. And I think that's the issue with how do you designate funding? How do you say what's enough? How do you say, this demographic or the TBI population only needs, $1 million. Every day there's a new survivor. Every second there's a new survivor. Then there's also a new caregiver. So there needs to be funding wrapped around that, or a slush fund where it's kind of a moving target. So I just think people need to understand, we need to get ahead of the problem instead of being always playing from behind, So that's just kind of my little spiel.
Come on, Renee. Okay. Maria, did you want to add anything?
No.
Okay.
Eric did really good. So.
Excellent, excellent. Let's see, what are some other questions that are coming in here? Oh, and then the second part to Greta's question was, do you have any advice for a professional who wants to create ongoing care options for survivors who need more?
Partnerships. I mean, I think people spoke about that before, but I think the word that needs to go in front of partnerships needs to be strategic partnerships. You can partner with, all survivors at some point go through a food shortage. They go through electrical, they can't pay their electricity because medicine went up or something of the sort. Why are we not partnering with the local, utility companies and things of that nature to be able to, give them a tax write-off if they give out, $60 allowance to survivors or just persons with disability. I mean, I think that if we sat down and had these conversations, things can be had. I mean, but everyone wants to get something from it. It's like, hey, we have a grant and it's $5,000. Me and Maria have to split it, but I want more of it, but I want her to do the work. Like, no, we have to share because we're all in this together. The problem is everything is so, people are selfish, and that's kind of, it's like now with COVID, a lot of us realize how selfish we are because we said, man, I wish I can go outside. I wish I can go to the movies. I wish we all could go to the movies together. I wish we all could go outside together. Our TBI survivors, our thought process is we really care about a lot of people, but it's more of a selfish injury because you go through it and no one knows what you go through. So I just think we ought to just find strategic partners and actually sit down at the table and say, how can we all help each other in this process and we all get what we want to get,
Yeah, I agree with that, Eric. I think partnership is important. I'm a strong believer in using community organizations. Those are the people that have their feet on the ground. Those are the people that are going and it truly being peer mentors. They follow into the court system so they can understand what's happening through the probation area. If there's a food pantry program that's at one community organization, you can utilize that. If there's homelessness and they need showers, then they can set up those showers, or there's days where they could pick up clothing, and there's also access to where if you have, let's say you work in the hospital and you have to find resources for people with brain injury or disabilities, connect with your community organizations, find out, build up a resource list that can be consistent in being displayed always, whether it be on your website, your portals, or whatever you have. And I've found that during this period that we have utilized our community organizations here in Pueblo, and it's been an asset to us. Just this morning, we had a Zoom meeting, and a woman came on and shared how people with hearing disabilities can receive access to hearing aids. So I think it's using all the resources you can, but like I said before, I really believe it's not the guy that wears the white coat or what have you. It's the people that are working with the people that have to be connected with.
Becky, did you want to add anything to that?
I know that, your prior question about, funding like health insurance when it runs out, what do you do? As an outpatient, I have never really ran into that problem because my career prior to my injuries was teaching medical billing and coding. So
you're an expert.
So, and I was very fortunate to obtain a physician who works with me if we need a letter for equipment. He gives it to me. If you need extra therapy sessions, whatever. So I've been very fortunate in that aspect. And I know Eric was talking about the communication as far as Zoom. In my home state, we do not have fiber optic internet anywhere in the state. So, it is very aggravating trying to have a visit with your, even just my PCP, and it cuts in and out. And yes, it's very aggravating. People get frustrated, they don't want to do it, kind of give up on technology. I can assure you that with Zoom, it is HIPAA compliant, so you don't have to worry about your birthday, your social security number, things like that. But I guess that's all I have to add.
I didn't know that about Zoom, that it was HIPAA compliant. That's very good to know.
Yes, the physician has to pay for it, but it is an expense that they pay for.
All right, we've got time for a few more questions, I think. One question here: what does the panel think of the percentage of individuals who potentially have TBI but are not aware that they do?
I think we all have some sort of TBI. I mean, I didn't roll over and hit my head on the wall when I was asleep. So I feel like we all just, you can sneeze and rattle your brain, so I think we all have had some sort of trauma. I just think, people should just, I think safety is everything. I've seen a couple of comments about, football organizations, or someone in the chat was saying about they want to go to support groups, but it's always negative. Just the fact of the trauma itself of just beating yourself up is something within itself. So I'm always positive, you know, the glass is half full, you know, just like Becky said, you know, when I broke my neck, I actually was paralyzed from the neck down. Most of the people on this call have seen me before. They would have never guessed that. But the doctor told me, hey, you'll never walk again. And I said, you don't know who I am. I'm actually something special. I'm from another planet. And then one day I was able to move one finger, then two fingers, and three fingers. And now I can walk again. But I never gave up inside of my mind. And so when I go to support groups, I only focus on everyone on this call is better than they were when they had their brain injury. You got into a car wreck, you were very injured, now you're better. So you made progress. So just appreciate the progress. Appreciate where you are. So I think of it like that instead of saying, but I used to be a mathematician. Well, hey, you know, maybe you make like, you know, English now or something. So I've always focused on the positives, and that makes the support group just it just seems better when everyone's just having fun and enjoying life and talking about the day's, you know, current events, you know, things like that. So.
Pierre Maria, anything you want to add?
You know, I just want to, I'm like Eric, you know, the groups that we provide right now, we try to focus on, you know, I want to hear people laugh. I want to hear people find that inner strength again, you know, that we have some very talented people. And I would hope that people could, the community businesses that we have and organizations that we have, bring in people with disabilities, with brain injuries, et cetera, because they're so creative. You know, they're talented people. They always want to give more. They always want to give more. And I think when you allow people to become resilient and want to give back, I think it just makes our recovery and our ability to have a introspection of ourself that says, you know, we're part of this again. We're human. We're part of being back in the mix. And I think that's what a lot of people miss. You know, you want to be back in the community. Nobody wants to just stay at home and just wait for their next medical appointment. You know, we want to get out there. We want to do some stuff. You know, so I'm like Eric. I like to focus on the positive. You know, and I want to see people accomplish things. You know.
Yeah, there is something I was thinking about. I've had family members and friends say, well, I don't know what to say to you because of your injuries, so I just choose to say nothing. And emotionally, that you depresses a person because you say nothing. It's like I don't exist or I don't matter. But I think that people need to be taught a new attitude, that rather than saying nothing, try saying, how can I help? You know, how can I help? Do you need to ride somewhere? Do you need groceries? You know, and if we all come together and form that positive, you know, and try to turn that negative into positive, just the outlook is much brighter.
I'm going to piggyback off of that, turning the negative into the positive, with a question here from Stacy. And she says, when I go to a peer support group, I get tired of hearing all the negative. I'm struggling myself each day, so I need to hear positive, see positive. How do we keep peer groups from falling into the hole of negativity?
Easy. You got to go first and say something funny. I like to start off with a joke, and then go into something, go into something good. And then it's hard to, it's almost like negativity breeds negativity. So most of us, especially depending on which part of the tunnel you are in, most of us are kind of just walking into the tunnel. We're just fresh brain injury survivors. We don't know what to expect. We Google, we talked to Dr. Google and he said, oh, just drink this medicine and your brain injury will go away. And then the person does it and it doesn't work. And then they kind of go back and forth. They find a support group. The first time they don't say a lot. And then they start to, fall into the negative track. With our support group, I try to stay away from when I was going with, I try to stay away from everyone go around the room, say their name and say their brain injury. Because then it's just negativity. It's just like it's like a nightmare. And then by that time the day is over and it's time to go home. So I try to say, hey, tell me something good you did today. Tell me something funny. Tell me something you saw. And then we start there because it just builds upon itself to now the conversation is more positive. We turn on the lights, we make sure the windows are cracked, just things that makes things a little bit better.
Yeah, I for me, I like that too, Eric. I think I'm a strong believer that you have to have group participation. You got to incorporate people. So if you have a writing assignment, a class or something, and you talk about the foods that you ate when you grew up, you're going to find out what people's cultures are. You're going to find out where they were raised, what ethnicity they were, and it brings up a whole different ballgame. And it brings a different kind of conversation. So it's kind of like for March Brain Injury Awareness Day or month. Let's come up with a T-shirt, a tagline, and let's get it done. And that's, to me, is how you incorporate people and bring them together. And if there's something that has a glitch in it, like maybe there's a disagreement, then you work that out. You start learning different ways of communicating. And I just think that support groups have to be tweaked a little bit. Because it was good back in the day, and now we're here today in a different kind of environment. And I think we need to reinvent ourselves with that a little bit.
Becky, did you want to add anything?
I agree about being interactive with your support group. I think Eric said he liked to start off with a joke. My health insurance actually sent me a Fitbit because I had improved my health over the past year. And there's an app on Breaking the Ice Conversations. You can download it from the Google Play Store, that's a conversation starter jokes. So, even getting that out there is make it part like a role. Everyone in the group starts out with an icebreaker joke to try to get them interact.
Yeah.
That's impressive. You improved your health over the last year. I think most people's health while being at home is taking a bit of a nosedive there.
I improved it so much that I have Humana insurance, and they sent me a Fitbit, a scale, blood pressure cuff, thermometer, the wand to sterilize things, just a whole package to go to work.
I think we have time for one more question. I'm going to make it a kind of fun one. I want to know like, what are your dream supports? Like, what do you, if you could have any supports or services that would help you live your best life with a TBI, what would that look like?
If I was to have my dream support, I would have Denzel Washington be my doctor, and he would just, you know, just recite movie lines to me all day long. I just enjoy Denzel Washington movies. So that would be it. I just want Denzel Washington in the house with me. That's pretty much it. So
We'll work on that. Maria or Becky?
I'm still thinking about what Eric said, but you know what? I think my dream support would be if policies in our in social services and receiving care and things like that, if it was all consistent and easily able to be reached, you know, for everybody. I don't care if you're in a community of 100 or you're in Pueblo or on the outskirts or what have you, you know, if there was just one place that you could just have the information all be equal and simply said, if you have a brain injury waiver in that county, use that brain injury waiver. If it doesn't exist, don't tell people it exists and then you don't use it. I mean, to me, it's just consistency. That's the flow of information has to be consistent.
Becky?
My dream has already been met just by finding the disability rights and being introduced to all the services that the rehabilitation / nursing home did not introduce me to. So just knowing that someone is out there listening, trying to help me, to help others who were in similar situations. That's my dream. It's hard to come true.
Awesome. Well, thank you guys so much. I'm sorry we don't have time to answer any of the other questions. We do have to do a little bit of wrap up. But I know Eric put his email in the chat here, and Maria or Becky, I don't know if you're comfortable doing that, putting any of your contact information in the chat for anyone who might want to follow up with you. That would be great. And then now I'm gonna turn things back to Tom. We have some evaluation questions that we'd love folks to answer that just help us to figure out how to make these webinars even better in the future.
Right, so we've got some webinars coming up, as you know, the TBI Tuesdays, there's 4 more of those. And so we want to make sure those are as good as they can possibly be, but we are constantly creating other webinars as well. So your evaluation and feedback on these will be very, very helpful. It's another poll. So it's real time. You don't have to take it back and then worry that you have to do it or have to send it later on. We'll just take a couple of minutes, do it right now, and answer the questions, and then we will let you go for the day. So the first question, as you can read there, is overall, how would you rate the quality of this webinar? The next question down is, how well did the webinar meet your expectations? The next question is, do you think the webinar was too long, too short, or about right? How likely are you to use this information in your work or day-to-day activities? How likely are you to share the recording of this webinar or the PDF slides with colleagues, people you provide services to, or friends? I believe that is, there's 5 questions. Is there more? Did I miss 2?
No, there's 5.
Just see 5, okay. I want to give you a few minutes to do this. I don't think we're gonna rush anybody on this one. While you're answering these, I do want to again thank all of our panelists, all of our speakers today, Rima and Alexa and panelists. And I don't have their names in front of me, so I don't want to leave anybody out, so I'm not going to try to do that. I really appreciate everybody's input today, particularly the survivors, TBI survivors. Your perspectives on things are invaluable to the work that we're all doing, and invaluable to our advocacy efforts and to our policy efforts, as well as our services and building up good structural supports. If there's any thoughts that anybody has in addition to this evaluation, these short evaluation questions, if you'd like to send us feedback at any point, I'm going to put my email in the chat, and so you can see, you can send it to me, or you can send it to any of our, you can send it to me or to Dana or to Terry. Any of us speakers can get that. My email is, if I can type correctly.
Terry just put our emails in there. Oh.
Okay. You did it already. But please go ahead and send us any feedback you'd like. Also ideas for future webinars, speakers, people that you know who would be a good person for everybody to know, that kind of thing. Any way you would like to become involved, let us know. We're very interested in making these connections. This program is born out of a federal grant program. All of this is born out of a federal grant program called the TBI State Partnership Program. But the TBI State Partnership Program is a tiny little bit of money. It's about $6 million across the country for every state. It's such a little amount of money, it's almost embarrassing. But we struggle every day and strive every day to make sure that little bit of money has a much bigger footprint in its impact in the community. And the way we do that is by building relationships with all of you and with each other and organizations and other states and all of those things. And so please reach out to us. Don't hesitate. If you've got questions, if you've got ideas, if you've got thoughts, comments, feedback, whatever, if you want more information about something you saw today, I would love to hear from you. That said, I'll turn it, we're after 4 o'clock. Terry, do we need to say anything more? Terry's in charge of all of us. I'm asking her.
No, we're good. Thank you very much. This was a great session, and thank you. Great kickoff.
We are going to email a PDF version and a recording, I believe, to everyone who is registered. And then, we'll email the PDF to everyone who is registered, and then the presentation and recording will be posted on our website on acl.gov.
And we'll give you a link to that, I think, right? Yeah. So please come back next Tuesday, same bat time, same bat channel, and we will look forward to that. Thank you, everybody.